Greetings from Kerala. The art form that you see on screen, called Kathakali, is loved by people world around for its ability to create magic. In dentistry, we do, but we can create more magic if we are open and embrace new materials, new techniques, and technology. So my lecture for today is revolving around one such material, Tricalcium Silicate, focusing on its use as an obturation material. So the rationale and the strategies that I use is, tricalcium silicates have bioactivity, they have excellent anti-inflammatory properties, and they aid the pulp in antibacterial properties by enhancing complement activation. Now coming to resorption, the use of tricalcium silicate in resorption, the material that I use has a compressive strength of 300 megapascal, which is very close to actual dentine. So it reinforces the tooth from within. And using it for obturation has different benefits. Also, tricalcium silicate is one material which can induce bone formation, it can induce dentine formation, and it can also induce material which is very similar to cementum in nature. Regarding irrigation, mostly I try to use 5% sodium hypochlorite, except in cases when there is a lateral defect and there is a communication of the resorption with the bone. And calcium hydroxide, especially in resorption cases, because they counteract the action of osteoclast, it stimulates the production of alkaline phosphatase, and it also helps to disinfect the tissue that you cannot remove in a resorption case. So coming to the cases, we'll start with the resorption case. A young patient, external root resorption. The protocol was cleaning and shaping, sodium hypochlorite 5%, medication with calcium hydroxide for 2 weeks. This is 9-month follow-up, this is 12-month follow-up, and this is a 2-year follow-up where you can see a change in the root architecture starting to happen. Another case of root resorption, this time in a young patient with a history of orthodontic treatment, the tooth is non-vital, severe resorption in the distal canal, and you can see a 2-year follow-up again with excellent healing. Now this is a difficult case, severe resorption, long history of trauma, poor endodontic treatment was done first, and you can see from the IOPA and the CBCT images the extent of the lesion. There is a lot of loss of both dentine and bone. This is the situation. So we still decided to move on with a non-surgical treatment, and the same protocol was followed. This is obturation. After 3 months, you can start to see healing happen. This is 6 months. This is 2 years follow-up. At 2 years follow-up, we have taken a CBCT, and then you can see the bone starting to reform, excellent healing around the defect, and this is the final picture after 2 years. This is another case of resorption, but then in this case, I have not used bioceramic as an obturation material because it is not involving the apex. So it is only using MTA to obturate the defect, followed by a hybrid obturation with gutta percha. This is a case with a very poor prognosis because the patient is very young, and then we had no prosthetic option available. It was decided to retain the tooth in place. The patient had swelling, pain, and slight mobility of the tooth with a history of avulsion. And this is after obturation with tricalcium silicate, and this is a 2-year follow-up where the tooth is still in function and the patient is symptom-free. So moving from resorption to another indication, which is apexification. Apexification I've included in this presentation because my strategy of obturation has changed. Initially, we used to make an apical plug with a bioceramic material, followed by a gutta percha obturation, like in these cases also. Instruments projecting out, remove the instrument, obturation with tricalcium silicate, followed by obturation with gutta percha. But then nowadays, what I try to do is, I try to complete the obturation on one single visit, the entire canal with tricalcium silicate. This is more easier to do and more predictable to do. This is a case post-op, immediate post-op, 6-month follow-up, and by the end of 2 years, we are able to start orthodontic treatment for this patient. This is another case, again same technique, apical plug first, then complete the obturation with tricalcium silicate. From apexification, we move on to revitalization. Again, it is same as apexification, but the strategic placement of tricalcium silicate will differ according to the case. This is no instrumentation technique used. This is 2-year follow-up. Another case, similar case, again lower molar revitalization, 17-month follow-up. This is another case, third case with a larger lesion. Again, 2-year follow-up with excellent healing and repair. This is an anterior case with a history of trauma with a cervical root resorption and an open apex. Again, a similar treatment is being done and the patient is being monitored. This is a 9-month review. From revascularization, and this is another case of avulsion, a case in which revitalization was attempted in an avulsion case. And this is a 18-month follow-up where again we can start repair, we can start to see repair and the architecture of the root starting to appear. From revitalization, let's move on to fracture. Tricalcium silicate can sometimes be used in fracture cases. This is a vertical plus oblique fracture in this patient. And I've placed tricalcium silicate slightly above and beyond the fracture and then did a composite restoration both from the buccal and the palatal to reinforce this fracture. And this is a 3-year follow-up of the case. Let's move on to another indication, that is complex anatomy. In this case, you can see it is a type 1 dense invaginatus case. A type 1 dense invaginatus does not usually require tricalcium silicate to manage, but in this case, we also had a periapical resorption, so I decided to completely obturate the canal and the defect at the same time using tricalcium silicate. This next case is a little more tough case. It is a type 3B dense invaginatus case, as you can see from the CBCT. You can see resorptive changes, you can see the large defect and the large periapical lesion. And the pain point in this case was trying to locate the canal, because every time I'm putting a file inside, it is slipping to the defect. So after several attempts, I decided to completely remove the partition between the canal and the defect so that I could locate the canal. So after locating the canal, the second pain point was to obturate, obturate the defect while keeping the canal intact. So the canal was patent and intact, and you can see obturation with gutta percha. And this was followed by a composite restoration. This is a 2-year follow-up of the case, and you can see good healing and good dense filling. We move on to iatrogenic damages, which are caused by the dentist. This is a case where I had to do a surgery, and because the access was very limited because it was upper 7, I decided to obturate first with tricalcium silicate and then do a root resection because I wanted to avoid retrograde filling in this case. And the next cases are all cases where the apical foramen has been damaged, and I've done a tricalcium-based obturation so that the integrity of the apical foramen is not lost. And finally, I would like to show you my last case, which is a non-surgical treatment of a surgery case. A surgery case which was relapsed, and instead of doing one more surgery to repair the apex and shorten the root again, I've done an obturation with tricalcium silicate, and this is 3-month follow-up of the case. So magic can elicit different responses from different people. It could be skepticism, it could be wonder, it could be joy, or it could be hope. Thank you.
Thank you, Dr. Jose.